From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello and welcome to the JAMA Clinical Reviews podcast. I am your host, Dr. Mary McDermott, Deputy Editor of JAMA and Professor of Medicine at Northwestern University Feinberg School of Medicine. Today, I'm joined by Dr. Mikkael Sekeres, who is Chief of Hematology and Professor of Medicine at the Sylvester Comprehensive Cancer Center at the University of Miami Miller School of Medicine. And today we'll be talking about Mikkael's review just published in JAMA on the myelodysplastic syndromes. Welcome, Dr. Sekeres.
Thank you so much for having me.
So let's begin by having you tell us, what are the myelodysplastic syndromes?
To be completely honest, I think I've spent the past 20 years of my career trying to figure that out myself. The myelodysplastic syndromes are a heterogeneous collection of clonal hematopoietic disorders that obviously originate in the bone marrow. Myelodysplastic syndromes are a type of cancer, and they're very similar to acute myeloid leukemia. So they start with a bone marrow stem cell or some primitive hematopoietic element that acquires a mutation. And that mutation causes that cell to grow abnormally. It causes a block in differentiation, so those cells don't mature normally. And as a result, it compromises the production of normal blood cells. For myelodysplastic syndromes, the most common cell line that's affected are the red blood cells, but it could affect the white blood cells, the platelets, or all three of those cell lines. Because myelodysplastic syndromes is a type of cancer, as you might expect, the bone marrow has too many cells in it. It's hypercellular. You have the uncontrolled growth of cells that encroach on normal tissue, on the normal production of blood cells from the normal bone marrow hematopoietic elements.
So how common are the myelodysplastic syndromes, and also who is at risk?
They affect approximately 4 per 100,000 people in the United States and have a slight male predominance, so a yearly incidence rate of a little over 5 for men and about 3 for women per 100,000. But as people age, they become much more common. So the yearly incidence rate actually increases to 25 per 100,000 in people 65 years and older, and the median age at diagnosis of myelodysplastic syndromes is approximately 70 years. Roughly, this translates to about 20,000 new diagnoses of myelodysplastic syndromes in the United States each year. Prevalence estimates are really tricky. So I've seen estimates for myelodysplastic syndromes that range from 60 or 80,000 people living with it in the country all the way up to 150,000. And it all really depends on what people are calling myelodysplastic syndromes. So it probably comes as no surprise the biggest risk factor for developing myelodysplastic syndromes is age. But other risk factors, and probably the most common question my patients ask me is, what caused my MDS? About 10% of MDS can be attributed to other causes. The most common causes are people who receive chemotherapy or radiation therapy for other indications, most commonly cancer. So, for example, a woman who gets treated for breast cancer with chemotherapy and radiation therapy is at a higher risk of developing myelodysplastic syndromes years afterwards. Same thing for somebody who is treated for lymphoma. There are environmental toxins that can lead to the development of myelodysplastic syndromes, but these are really hard to quantify. I think the most famous example is probably the atomic bombs that were dropped in Hiroshima and Nagasaki in 1945 that actually led to higher population incidence rates of myelodysplastic syndromes in Japan 30, 40, even 50 years afterwards in those who received high exposures to the atomic bomb.
Oh, that's really interesting. What are the typical presenting signs and symptoms of the myelodysplastic syndromes?
A typical person, as I mentioned, who has myelodysplastic syndromes might be about 70, 71 years old. And that person may go to his or her doctor and say, I've been tired. I just don't feel right. My appetite is kind of waning a bit, and I just don't have the same get up and go that I used to. Now, I think a good doctor who's evaluating that will start with things that are common in people who are older. That might include a check of blood counts. It might include an EKG. This may lead down a route of evaluating causes of anemia. Anemia is the most common blood manifestation of myelodysplastic syndromes. So that may include somebody undergoing an EGD, a colonoscopy, a check of vitamin levels, iron levels, to see what other causes of anemia may be. And eventually, when other causes have been ruled out, a person is often referred to a hematologist for a bone marrow biopsy and aspirate. So most common presenting symptoms are related really to anemia or thrombocytopenia or neutropenia, one of these low cell lines that's caused by myelodysplastic syndromes. For anemia, as I mentioned, that may be kind of a general feeling of inanition. So I don't have the same get up and go. I feel tired. I will climb some stairs and have to rest. Patients may be short of breath. They may have a loss of appetite. They may complain of headaches or fuzzy thinking, all things related to anemia. Somebody who has a low platelet count from myelodysplastic syndromes may complain of bleeding, or they may say they have a rash, which may actually be petechiae. Or somebody with a low neutrophil count may complain of frequent infections.
And so, how is the diagnosis of myelodysplastic syndrome made? And perhaps you could summarize the main criterion.
Oh, sure, absolutely. So it starts, as I mentioned, with a person who's discovered to have low blood counts. Eventually, after other causes, more common causes of those blood counts that are low are ruled out, a person is referred to a hematologist and undergoes a bone marrow biopsy and aspirate. And we simply cannot make a diagnosis of myelodysplastic syndromes without having a bone marrow biopsy and aspirate. Years ago, people tried to do some epidemiologic work to figure out how many people were living with myelodysplastic syndromes in the United States. And it was discovered that a lot of reporting through either SEER or linked SEER Medicare databases or even North American Consortium for Cancer Registry databases actually never underwent a bone marrow biopsy. They were being listed as having myelodysplastic syndrome without that diagnosis confirmed, and that inflated prevalence estimates of how many people were living with myelodysplastic syndromes in the US. So we need a bone marrow biopsy and aspirate. The basic criteria then for myelodysplastic syndromes are going to include a normal cellular or hypercellular bone marrow. My experience, hypercellular is more common. You'll have patients who have evidence of dysplasia, and that dysplasia needs to be present in greater than 10% of cellular elements in a single cell line. So along the path that leads to red blood cell production, 10% of, for example, proerythrocytes need to be dysplastic, or they may be greater than 10% of megakaryocytes leading up to platelet production that are going to be dysplastic. This also needs to be in the setting of patients who have low blood counts. And increasingly, we're starting to define myelodysplastic syndromes and related myeloid bone marrow cancers by molecular abnormalities, so genetic defects that are starting to become the sine qua non of a diagnosis. For example, patients who have an SF3B1 mutation, it's something that's associated with having ring sideroblasts. So again, abnormal cells associated with myelodysplastic syndromes in the bone marrow. There are also patients who are being defined specifically by having a TP53 abnormality as having a myeloid malignancy associated with TP53. So to summarize, the very basis for pathologic diagnosis of myelodysplastic syndrome is based on morphology, on how the cells look in the bone marrow. Increasingly, we're pivoting more towards these molecular mutations to define myelodysplastic syndromes and related myeloid malignancies.
Your review discusses classifying patients with myelodysplastic syndromes into a higher and a lower risk. And I wondered if you could talk a little bit about those categories.
Absolutely. I don't know whether you're a lumper or a splitter. I tend to group categories so I remember them better, as long as that, of course, makes biologic and treatment sense. So we don't have a staging system for myelodysplastic syndromes. Once I talk with my patients about how myelodysplastic syndromes is a type of cancer, and I do this deliberately so they understand really just what a dramatic diagnosis myelodysplastic syndromes is. I think we soft pedal a bit around patients and call it a blood disorder or a bone marrow disorder because they're older and we don't want to scare them. But the survival for myelodysplastic syndromes, stage for stage, is probably actually similar to non-small cell lung cancer stage for stage. So we use as a staging system something called the International Prognostic Scoring System in its revised form, and more recently in its molecular form. And this divides patients with myelodysplastic syndrome as having lower risk disease or higher risk disease. Those with lower risk disease will have very few cytopenias, so maybe an isolated anemia. They will have a low blast percentage in the bone marrow, so let's say less than 5% blasts. And recall that once somebody has 20% blasts, that person is diagnosed as having acute myeloid leukemia. So less than 20%, we would say that person still has a myelodysplastic syndrome. And we define it by cytogenetics, the karyotype. So for example, in myelodysplastic syndromes, patients who have a -Y abnormality, a normal karyotype, deletion 5q, deletion 20q, have relatively good risk cytogenetics, whereas those who have a chromosome 7 abnormality, chromosome 3 abnormality, or complex karyotype where you see a paragraph long of abnormalities have a poor risk karyotype. So for lower risk patients, to summarize, patients have an isolated cytopenia, maybe an isolated anemia, a low blast percentage, typically less than 5%, and good risk karyotype. Patients with higher risk disease, and for higher risk disease, the median survival for patients is really less than 2 years, probably close to a year and a half. These folks might have multiple cytopenias, so let's say an anemia and a thrombocytopenia, or anemia and neutropenia. They'll have a high blast percentage, let's say 17% blasts, so something greater than 5%. And they'll have a poor risk karyotype, as I mentioned before, chromosome 7 abnormalities or complex karyotype. All of these factors go into the scoring system defined by the International Prognostic Scoring System in its revised form. We give a patient a score, and if that score is less than 3.5 by the revised IPSS, we say that person has lower risk disease. If that score is greater than 3.5, we would say that person has higher risk disease, and we adjust our therapies accordingly.
Great. So that gets us to treatment. And as you just summarized, and in the review, treatment is selected based on whether somebody has lower or higher risk myelodysplastic syndromes. So perhaps we could start with lower risk myelodysplastic syndromes. Can you talk about treatment?
So for patients with lower risk MDS, no therapeutic intervention has ever been shown in a prospective randomized trial to improve overall survival. So if you start with that fact, you recognize that what we're doing with folks with lower risk MDS is essentially trying to reduce disease-related symptoms, lessening or eliminating transfusions, and trying to minimize morbidity associated with chronic anemia, thrombocytopenia, or neutropenia. And we base treatment on the predominating cytopenia. So for a person with anemia, we might start with an erythropoiesis-stimulating agent, such as recombinant humanized erythropoietin, or the long-acting version, darbepoetin, to try to improve the red blood cells, to try to improve that hemoglobin, and hopefully even to eliminate transfusion needs in those patients who depend on red blood cell transfusions. For patients who have a very specific cytogenetic abnormality, the deletion 5q abnormality, we might try the drug lenalidomide, which was shown to reduce transfusion needs in about 2/3 of patients who were treated with it for a median of over 2 years. For those patients who have those ring sideroblasts that's associated with that SF3B1 mutation, we might try the drug luspatercept, which was shown in a randomized trial to improve transfusion needs in almost 40% of patients for a median of about 32 weeks. For those patients who have multiple cytopenias associated with lower risk MDS, we start to get into drugs that I think can really be classified more as chemotherapy. So that might include the hypomethylating agents, azacitidine, decitabine, or there's a new oral version of decitabine known as decitabine cedazuridine.
How about the higher risk myelodysplastic syndromes? How are those treated?
Yeah, patients with higher risk MDS, they start to look a lot clinically like an older adult with acute myeloid leukemia, and the biology between higher risk MDS and older adults with acute myeloid leukemia is very, very similar. As a result, recently, the World Health Organization has recommended that we have a category called MDS/acute acute myeloid leukemia for those patients who have greater than 10% blasts. I think this is dipping a toe into the water of what it would be like to reduce the diagnosis of AML from 20% blasts in the blood or bone marrow down to 10% blasts in the blood or bone marrow. And frankly, my perspective, I think that actually makes a great deal of sense. So if you think of these folks with higher risk MDS as really having borderline acute myeloid leukemia, you recognize that we need to treat them quickly. And if we don't, their survival is really going to be measured in months. Our initial frontline therapy for these patients, again, are the hypomethylating agents. I'll start with azacitidine. This is the only drug that's been shown in a prospective randomized trial in patients with higher risk MDS to prolong survival compared to conventional care regimens. Conventional care regimens in that study consisted of best supportive care, low-dose cytarabine, low-dose chemotherapy, or typical AML, acute myeloid leukemia type therapy of 7+3. In that study, patients who received azacitidine had a median survival of 24.5 months compared to 15 months for those who received the conventional care regimens, and that was a significant difference. Now, something in that study must have been very, very special because no study subsequent to that has ever shown a survival advantage for a hypomethylating agent such as azacitidine compared to anything else. So much more typical survival for patients with higher risk MDS treated with azacitidine or similar hypomethylating agents is about 18 months. We can also use the drug decitabine, which doesn't have the prospective survival data that azacitidine does, but we believe them to be similar drugs, or as I mentioned, the oral version of decitabine, which is a decitabine-cedazuridine combination. For patients with higher risk MDS, because their survival is so awful, we do discuss with them hematopoietic cell transplantation, commonly called bone marrow transplants, at diagnosis. A hematopoietic cell transplantation is the only known cure for myelodysplastic syndromes. And in an era when we can use alternative donors, when we have approaches such as reduced intensity conditioning, transplantation, we can offer these treatment approaches to people who are in their 70s. And there have been a couple of studies looking at whether or not people live longer with transplantation. And I will tell you, it's a bit controversial. We do know that the only patients who have really long-term survival and even cure from their MDS did receive a hematopoietic cell transplantation. Whether a hematopoietic cell transplantation is better than simply using hypomethylating agents such as azacitidine or decitabine in every older adult is not known. So I do discuss transplantation with my patients up front. We have a very frank discussion about risks and benefits, and then I encourage my patients to make a decision based on how much risk they're willing to accept.
Do you think that bone marrow transplant will ever be studied for patients with lower risk myelodysplastic syndromes, given that there's really no cure for that?
It's a fabulous question. It's such a temptation to offer a transplantation, particularly to the rare adult who's younger. And I've treated folks who have myelodysplastic syndrome who are in their 30s, 40s, and 50s, very young. And there have been decision analyses that have looked at the role of transplantation versus non-transplantation approaches. And even including younger adults, for lower risk MDS, we hold off on transplant. The advantage time and time again is for non-transplant therapies over transplant. However, I only have a limited number of tools in my toolbox to treat myelodysplastic syndromes. So once I've treated a patient with lower risk MDS, and we've tried erythropoiesis stimulating agents, maybe we've tried luspatercept, maybe we've tried lenalidomide, maybe we've tried the hypomethylating agents, and their MDS has continued to rage on and they've become more transfusion dependent and more cytopenic, that's the point at which I will consider a transplantation for somebody with lower risk disease.
Can you briefly summarize the life expectancy and compare it between the lower and the higher risk myelodysplastic syndromes?
For somebody with lower risk myelodysplastic syndromes, their median survival is measured in years. Now, that may be as few as 3 years, that may be as long as 10 years or more. And I have certainly followed patients in my practice where I haven't even needed to treat them for years and years for their lower risk myelodysplastic syndromes. For higher risk MDS, as I mentioned, this is considered, I wouldn't say a medical emergency, but maybe a medical urgency to start some sort of therapy. When I'm staring at somebody who has a median survival that's measured in less than a year and a half, I feel as if I can't just sit on my hands if that patient desires therapy. Just as, to reflect on my analogy from earlier, for somebody who has advanced stage non-small cell lung cancer who is interested in therapy and has a good performance status and few comorbidities, we wouldn't just sit on our hands and say, no, let's just watch this for a while. So for higher risk MDS median survival, typically less than a year and a half, we initiate therapy pretty quickly.
Is there anything else you'd like to say about the diagnosis or management of myelodysplastic syndromes that we've not covered?
Well, myelodysplastic syndromes is a serious diagnosis. I think we've worked a lot over the years to emphasize how serious it is and to emphasize the fact that it's a cancer. And in recognition of that, the World Health Organization just a couple of months ago has recommended that instead of myelodysplastic syndromes, we refer to this group of diagnoses as myelodysplastic neoplasms to emphasize the fact that these are cancers. I think my one take-home point, if I were a primary care physician, I would recognize that someone who's older, we talk a lot about the body aging and the effects of that, and sometimes low blood counts are, I don't want to say dismissed, but they're explained as the bone marrow aging just like the rest of the body. And I actually don't think that's necessarily true. You need very, very little bone marrow reserves to have normal blood cell production. So if I were to see, particularly an older adult with lower blood counts and no clear cause through common causes like blood loss or vitamin deficiencies, I would refer to that person to a hematologist to assess that person for myelodysplastic syndromes.
I've been speaking today with Dr. Mikkael Sekeres, who is at the University of Miami, about his JAMA review on the topic of diagnosis and management of myelodysplastic syndromes. Thank you so much, Mikkael, for this really wonderful summary of your review. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Steffens, Lisa Hardin, Audrey Foreman, and Mary Lynn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.